Welcome everyone to day 2 of Lift 20, the Strata Virtual Summit. I'd like to introduce Dan Michelson, Strata CEO, to kick off our session this morning.
Hi everyone, my name is Dan Michelson and I'm the CEO of Strata. I'm absolutely thrilled to welcome you to day 2 of our virtual summit. For those of you who weren't able to join for our keynote yesterday, I'll just share one key stat. Joining you at this conference are over 1,500 of your colleagues from over 200 health systems, making this what's probably the largest healthcare finance conference in the world this year. Given all the challenges that health systems are facing right now, there has never been a more important time to listen to and learn from each other. To that end, we brought together an absolutely incredible group of CFOs to share their experiences and ideas as we talk about their road to recovery and how it can help yours. So let's dive in. To moderate our discussion, I'm going to turn it over to Cara Boaz. Cara has been with Strata for over 15 years and leads up our experience management team. And John Martino. John joined Strata over 5 years ago and serves as both our CFO and COO. Cara, John, take it away.
Thank you, Dan. And hi, everyone. I'm John Martino, Strata's CFO and COO. I'm very excited about the next 60 minutes in the discussion with the panel. One of the topics that we'll discuss in a few minutes is the change from a budget-based culture to a performance-based culture, a change that many of you are probably experiencing. I've been with Strata for over 5 years in the role of CFO, and more recently, as Dan mentioned, in the role of COO, which has really enabled me to provide support and leadership across many functional areas of the organization, which also might be a familiar approach in your organizations. At Strata, we've actually been running a rolling forecast approach for my 5+ years here. And in fact, Roper Technologies, Roper is Strata's parent company, has over 50 operating entities, and all of them run a rolling forecast approach. We focus on growth and review our targets on a quarterly basis. We don't really rely on an initial target that was set at the end of the prior year that quickly becomes outdated. The rolling approach is really a big change from my prior experiences in my career, but one that I absolutely just love. So I'm looking forward to the discussion today on all of our topics. And with that, I would like to turn it over to Cara, who leads up our experience management team, focusing primarily on post-implementation customer success. Cara?
Great, thank you, John. Glad to be here, everyone. Cara Boaz, our VP of Experience Management, and just a little bit about me. Our Experience Management group really came to be at Strata several years ago, and in an effort to make an investment in continuing to deliver on our mission, which at Strata centers around serving our clients. And as John mentioned, we wanted to be sure that we could focus on ensuring our client success, not just during implementation, but for the lifetime of our work together, and understanding how we best put Strata solutions in place and utilize those solutions to solve the problems that our clients are focused on. I've been with the company for just over 15 years. Prior to my role within the experience management team, I specialized within our financial planning group. So over my tenure, I've had the opportunity to really interact with nearly all of our customers. And so I can tell you this from a place of confidence. All of you, our 200+ health system strong network, is really one of Strata's strongest assets. As we talk to people at Summit year over year, the consistent theme that we hear that their favorite part is the opportunity to network and learn from their peers, which is why we're bringing with us today a number of CFOs from some phenomenal organizations at our customers. And our goal in holding this session is really for this group to provide some insights that all of you can be taking back to your organizations, whether that is providing validation around a strategy that your organization is also considering, learning about tactics that have been successful elsewhere, or simply getting some inspiration from other healthcare leaders in a time where it's never been more important for us to come together as a community. We'll really be focused on a few themes today: hearing about lessons learned, understanding strategies to consider, and talking about the road to recovery. So without further ado, want to introduce our panelists. So if all of you could turn your cameras on, and we'll really go through some introductions to start, and really in the order that you're pictured here. So Steve, I'll have you go first.
Well, hi, thanks for letting me join you today. My name is Steve Glass. I'm the Chief Financial Officer at the Cleveland Clinic. I've been with the Cleveland Clinic for 18 years, and the clinic is an organization that has for years been known as one of the top health systems in the country. We have about 18 hospitals domestically in the United States, as well as centers in Abu Dhabi and one under construction in London, as well as Canada as well. The organization has about $10 billion worth of revenue, so a medium, large size organization as well. Prior to joining the clinic, I was with MedStar Health, which is a large system in the Mid-Atlantic region. I was with them for 14 years and joined them right out of college. So it's a pleasure to be here. I want to thank Cara, John, and Dan for allowing me to join the panel today.
Thank you, Steve.
Hi, good morning. My name is Melinda Hancock, and I am with VCU Health. I'm the Chief Administrative and Financial Officer here at VCU Health, which is based in Richmond, Virginia. So I've been here for about 4 years. Prior to that, I was a partner with Dixon Hughes Goodman, working with their payment model group. And before that was with Bonsa Coors for 10 years. And prior to that, a small community hospital in Culpeper. And then before that, even some time with dating myself, the Big Six. So that's a bit about my career. Also want to share, very active in HFMA, was the national chair in 2015-2016. A little bit about VCU Health. We are in a bit of a transition period as a health system. We sold 80% of our health plan. So for the fiscal year ended June 30th, 2020, we were a $4 billion net revenue organization. And now owning 20% of that health plan has changed our net revenue base to a $2.5 billion net revenue base. So we are in the process of repositioning ourselves. We have an academic medical center here in downtown Richmond. We have a community hospital in South Hill. We're in the process of acquiring another community hospital in Tappahannock, Virginia. We have a children's hospital that we're in the process of building. And then we also have a long-term care children's hospital, and then a practice plan associated with the medical center as well. I look forward to being with everybody today. Thank you.
Good morning, everyone. I'm Karen Tessman, the CFO of Memorial Care. We're a not-for-profit integrated system that serves the South Los Angeles and Orange County coastal region in Southern California. And I joined the organization 22 years ago as a CFO at one of our hospitals and have been in my current role the past 8 years. I actually began my healthcare career as a registered nurse and then began my career in finance in public accounting as an auditor for Arthur Andersen and Company. A bit about our organization. We're a $2.6 billion organization. We have 4 hospitals and have invested recently in expanding our ambulatory network. We have about 80 primary care and clinic sites in the region. In California, we cannot employ physicians directly, so we have a quasi-employed structure. We have a medical foundation where we employ physicians through that structure. But for the most part, most of our medical staff are independent. We also have invested, as I said, in ambulatory, but pretty heavily through joint ventures in freestanding imaging centers. We have 35 of those, surgery centers, dialysis centers, and most recently, physical therapy centers. Have been very focused on growing our risk profile. We currently have about 250,000 at-risk lives and would really like to see that grow and double in the next several years.
Good morning. I'm Burt Zimmerley. I'm Executive Vice President and Chief Financial Officer at Intermountain Healthcare. So I kind of wondered why Dan, John, and Cara wanted me on this panel. And so I think there's probably 2 reasons. One, as you can look at the others presenting, they wanted someone who would bring the average age up substantially. So that was probably number 1. And then number 2, in thinking about this thing about, we can't call it a budget anymore. Now it's a dynamic plan. So they said if someone, that's kind of a dinosaur like Zimmerley can do this, then that'll be a great message to the market that anybody can do it. So seriously, I'm glad to be here. Like Steve, I've known Steve for a long time actually. And I learned this morning now he's been with Cleveland Clinic about a year more than I've been with Intermountain. I'm going on my 17th year. I spent 25 years in Houston, 16 with Ernst & Young. I was a partner for 7, and then Memorial Hermann and the Methodist, now Houston Methodist Hospital. So we're about 10 billion as well in net revenue. We're about 40% capitated or value-based if you look across our system. And our health plan now has grown from 5-6 years ago at about $1 billion of revenue. It's now 4 billion. And about a year ago, we acquired an organization called Health Partners Nevada from DaVita/United, who was blocked in the acquisition by the FTC. And that contributed another $1 billion. So we're very much into value, and I'm excited to hear what everyone has to say. Thank you.
Outstanding. Well, thank you, everyone. We really appreciate those introductions. So let's go ahead and get started. I know we can all agree that healthcare providers have been the real heroes during the pandemic. And while the pandemic has created many new challenges for all of us, really, accelerator of change. And what we'd like to do now is talk about some of the key initiatives that have been prioritized within your organizations, maybe more so this year than in the past. And there are several we've heard about in recent discussions with all of our customers, and we're going to explore a few of them today. So first, I thought maybe we just start out with a show of hands from the panelists, just talking through, if your organization is implemented or in the midst of planning to implement some of the following initiatives that we're going to talk through. So maybe just a show of hands for the panel. So digital expansion and telehealth. All right, 4 for 4 there. A more agile financial planning process, so a rolling forecast instead of the traditional budget-based approach, whether you're implementing it or about to. Okay, 4 again. This was not planned. Improving the affordability of care, which likely aligns with cost containment initiatives. All 4 as well, okay. And then lastly, a shift to value-based care. Okay, so as you can see, these are 4 topics that are really key to these 4 organizations, but really many of you in the audience. So let's go ahead and get started with the first topic, so digital expansion and telehealth. So many providers had existing initiatives related to investments in this and to improve access and reduce the cost of care. And it appears that the pandemic has obviously accelerated the work in rolling these initiatives out, and with organizations seeing telehealth visits rapidly growing in the past few months. So the question I have for the panel is this: what has your experience been over the last 6 months with digital expansion and telehealth, and how do you anticipate this evolving relative to your long-term strategy? So Burt, maybe we'd start with you and how this has impacted Intermountain.
Yeah, so as I've heard across the country, that obviously the televisits have exploded, probably anywhere from 4 to maybe 6 years earlier than perhaps they otherwise would have, as we look at the progression of this industry. But going back before that, we began investing in telehealth about 10 years ago, maybe 11. And at that time, I mentioned I was with Ernst & Young. When I was a partner and learned a little bit more about the finances, when the senior partners talked about we need to make investments, that was code for we're going to lose money for a long time on this. We started making investments in again, about 10 years ago. And at that time, I called it a faith-based investment. Now that didn't mean nothing to do with religion, but that you really couldn't put a legitimate business plan together with established assumptions that really proved you're going to have a return on investment. But you knew that if you were willing to modify as you went, if you were willing to be flexible on the number of years before this would become important, you kind of knew it had to happen. And so we're fortunate at that time, it was more about tele-ICU and some of those things. that we did. And then about 3 years ago, we went, well, I would say we went all in on digital. And we've invested a lot of money working principally with the Boston Consulting Group and others to hopefully approach, through Intermountain, but from a health perspective, what most other industries already have. Real digital experience where you can take your smartphone, you can make an appointment, you can look at your medical record, you can pay your bill, and you can get a lot of the care without ever going into one of our facilities. So I would probably leave it at that.
Great, excellent. So Intermountain was definitely on the forefront here. So Karen, same question. I know you mentioned in our previous conversation the idea of ease of access. So I'm curious in how digital expansion and telehealth has impacted memorial care.
Yeah, thank you. And similar to Burt, we're on a journey with telehealth, but it's been a much more recent experience for us. We had put together a really 18-month to 2-year digital roadmap, and with COVID ended up putting in place virtual visits in about 2 weeks. And so that 18 months got condensed pretty quickly. But to your point about ease and access, that's something that's been part of our strategic plan the last couple of years. We're about a year into that journey, putting together or implementing a plan that our lean value stream put together for us. And it's really 3 things that we're focusing on. One is in person. The second is, phone. And so we've put together a navigation center. And the third is online. And so really expanding our digital capabilities. On the in-person side, it's making sure when that patient is in a clinic and needs follow-up care, that appointment is booked for them before they leave. So we make it easy for them as they're on their way out, checking out. We say, what diagnostic test you need, anything else, do you need to see a specialist? So we look at that and we get that booked for them. In terms of phone, as I mentioned, we put together what we call a navigation center. So it's really a call center on steroids, if you will. So we have some nurse navigators that can assist patients that call in to help direct them to what they need, help them book appointments if that's what they need, effectively just navigate around the health system to get what they need. And then the third piece, as I mentioned, is online. And so really expanding our technologies with MyChart, using ZocDoc, Clockwise, making sure that we have tools in place. So as Burt mentioned, to make it easy for the patients to book an appointment, change an appointment, get the information they need, access their medical records, and so forth.
Excellent. I know in the last week, I live here in Illinois locally, and I go to Edward Elmhurst, and so I booked my annual physical. And what was amazing for the first time is I get lab work before I go in, and they connected me right to the lab and made an appointment with the lab, which is new this year. So it was pretty amazing. So it was really easy to maneuver around, and they connected me via phone. So it was pretty interesting. So thanks for that, Karen. Okay, so maybe we'll move on, if it's okay, to the second topic, which is a more agile financial planning approach, which is one of my favorite topics, being a CFO. We found that over 25% of our customers have adopted an agile financial planning approach, shifting away from the budget-based culture to a performance-based culture that enables continuous improvement, more rolling forecasting. Health systems that have made this health systems that have made this transition have found that it also requires and enables a broader role for finance, including the CFO role. So Melinda, I thought maybe we'd start with you, since I know that in addition to your role as CFO, you also lead up strategy for the organization, and VCO has actually rolled out a financial planning approach. So can you tell us how that's impacted your organization and your day-to-day role?
Sure. So I am the Chief Administrative Officer and the Chief Financial Officer, and I've been that for 2 years now. So I am over strategy and finance and governance for our shared services. So our ability to kind of tie strategy and finance together, I was taught that years ago, and I find it very valuable. I think the ability now from a dynamic forecasting perspective, we started that about 1.5 years ago. We're still maturing it, in all fairness. I think getting, whether it's our governance structures or operational leaders, it's still a process, but I'm very thankful that we're in this process right now in the pandemic. So we just had a board meeting last week and assuring our finance committee that as we're looking at our first quarter results here in a couple of weeks, that we will bring back to them any adjustments we might need to make as we're moving forward to the operating and the capital budgets. It's really important. Our ability to constantly be scanning the environment, how it applies, what does it look like going forward? Because our top line is so variable right now, and all we can really work on in earnest is making sure that we are nimble and understand our expenses, and also making sure we're optimizing the revenues as well. So we've been undertaking value and efficiency work for 3 years, taking about $100 million of expenses or optimized revenues into the system. So we've been successful. We've made our targets each year. And now we've decided to extend that work. And a lot of it's supported by our costing systems and now our dynamic forecasting and our ability to get accurate targets for the different areas. So we have another $100 million target for the year that we just started. And we're probably going to need that through 2025 because we are ultimately looking at what does it take to break even on Medicare. And so really working with all the different tools that we have in place to do that. So it's all kind of come together nicely. Obviously we had no idea a pandemic would underline the need for this flexibility, but it does all help us forecast the next couple of years.
Great. And then, so you said a year and a half in, do you foresee ever going back to the old way?
No, it's interesting because even those who are still getting used to the concept, I think now, especially, given we did a lot to de-risk our fiscal 21 that started July 1st. And I think as we work through de-risking 2021, given the variability within it between the election and the pandemic and everything else that's before us, I think the ahas were just everywhere. And so even those who are just like, okay, what exactly are we doing? I'm so used to the mindset of I have to approve an annual budget. I have to have this. I think there was just been a lot of ahas in the last several months.
Great. Thanks, Melinda. I appreciate it. So Burt, same question. I know Intermountain's in the process of implementing an agile financial planning approach, and you're not quite implemented yet, but how do you think that will impact your organization and your role specifically?
Well, I guess a year from now, maybe I'll be able to answer that question. But I would say we started to implement without the systems really right about when this pandemic started. And, the first thing we did was said it was obvious that things had changed. Middle of March, I think it changed for all of us as a practical matter. And, you can't have your revenues drop 40% or thereabouts. And, for us, we didn't do furloughs. So if anything, expenses went up a bit as we got rid of volunteers for a while and as we paid more for PPE and stuff like that. So we looked really hard at monthly cash flow forecasts, put together a pretty sophisticated short and longer term restructuring of costs across the organization, that once we got a feel for what the ongoing revenue run rate was going to be, then we were going to make, the adjustments on the cost side, more in the labor and benefits, if you will, that side of it. So, but we are actually this week, Monday, Tuesday, Wednesday are the first presentations to our senior group, myself, our chief operating officer, chief medical officer, of the dynamic planning process. And it's going well. I'm kind of an old guy, as you know, as I've said, that I'm still a believer in a 5-year plan and having a real good idea where we're going to be, having those targets, maintaining strong relationships with the rating agencies, and letting them know here's what you can expect of us, and we're going to try darn hard to meet those numbers. They understand this year is kind of almost a throwaway year, if you will, but they're going to expect us to be back on track. I think the dynamic planning process, certainly it's our expectation, is this will help us move quicker, hopefully won't lock people in to it's either in the budget or not in the budget, if you will, as we go forward. So we're very optimistic about it.
Perfect. Yeah, and it'll still allow you to do those long-term plans. So I think you can do both. So it's gonna be interesting. I look forward to see how your organization how it transpires over the next year. So thanks for that, Burt.
Yeah, I did have one question for both of you, just knowing we have a lot of discussions with clients that are exploring making this type of a transition and approach. And one question we get often is, what if we're not performing well financially? If we see something that's a downturn, are people still comfortable with not having kind of the traditional budget to lean on in that? And I know, Burt, you all are still working through that transition, but you might have perspective. But Melinda, in particular, was that something that ever came up? And would you give any guidance, to other organizations that are, still uneasy about making that kind of a change?
Well, I think what I appreciate is the realism that I'm dealing with right now. This year is, I have a realistic forecast in front of me right now, and it's a rolling forecast, but it then feeds to Burt's excellent points about, I agree, I always have to be looking several years out. I'm in the middle of my ratings review right now, and it's really important that I have a view towards the future, but I also need to make sure I also have a realistic forecast. How many of us have prepared a budget that was good as the day you did it? And then a week later, your underlying assumptions change so fundamentally that you're explaining it for the next 11 months. So what this does is it takes that out of it. So whether it's a positive or a negative adjustment, it resets and takes that noise out so that you can focus on, okay, so here's the new realism that's entered my world. Here's now what I need to do, whether I need to ramp up maybe some constraints, or I need to think differently, or I need to move up some projects, or maybe pause some projects. It helps present, instead of, being the CF knows that we don't want to be, it invites the conversation to say, no, okay, so here's the environmental impact of what we're dealing with, and everybody can kind of level set to where we are. It just invites a much more rich conversation.
Yeah.
I might add to that, again, 16, 17 years ago, when I started, one of the things that was a little bit unusual, I would say, was an expectation that finance have a much stronger relationship with operations. And at that time, things had broken a little bit at Intermountain in that regard. And so that was a clear expectation: build solid relationships, work as a team, be a coach, if you will, for the non-financial people versus, I think sometimes we can, hopefully not, on purpose, but inadvertently send dummy messages maybe. And so we've worked at that very hard ever since. And I think now it's even more important. Though I would say as a CFO, don't let yourself be the only person responsible for the budget. In fact, in a lot of ways, it's probably more important that the COO, really feel direct accountability. We're fortunate at Intermountain. Rob Allen's our COO, and we're really locked together on this. And again, if you can bring your chief medical officer in as well, depending on their position in the organization, probably your chief nursing officer, and work as a team. We have monthly meetings that we look at this together. So it's not, the finance people always presenting the financials or being accountable. So if you can move toward that, I think it'll help in a lot of ways.
I think that's a fantastic point, Burt, and it parlays well into the topic of both affordability. How do we, as you all as leaders of finance, really continue to help create affordable healthcare for your communities and constantly assess the cost structures that are in place. And I think what we find too is, particularly as all of you have, where there is a focus and strategy around the shift from fee for service to fee for value, that becomes that much more important as our revenue becomes, more capitated. So I was wondering, maybe Steve, if you could start us off and talk a little bit about what that's looked like at the Cleveland Clinic.
Yeah, well, thank you. Well, one, I think it's important to start by talking about what the clinic really is. We were established as a physician practice group at our core. So we're not a health system that's now in the business of employing doctors. We have from day one been a physician practice group. And that's important because as you start to talk about how you manage across an entire enterprise from a service perspective, right? So this isn't about how many patients get admitted to a certain hospital or how many surgical cases you do at that hospital. This is how do we take care of our community along those particular services that are needed in that community. And then it becomes a conversation of what is the best cost structure, location in order to facilitate that. And we have to take things into consideration like access, like reimbursement, like cost, but really being able to step back and not take the traditional approach of a hospital looking at that. So for years, we've been on this mission of migrating away from independent silos of hospitals or family health centers to really, how do you look at how we handle cardiothoracic care across the enterprise? And, 15, 20 years ago, that was what's here in Northeast Ohio. But then as we've continued to grow and we think about doing that in Florida, as we've done that in Abu Dhabi, and now as we do that in London, NeuroCare in Nevada, all of these things are all part of one service line across the organization. And what we've really been doing is then building across that these centers of excellence that exist. So as an example, the clinic has a world-renowned transplant program. When we decided to open up Cleveland Clinic Abu Dhabi, and we recruited those physicians, and actually Burt's boss was heavily involved in this when he was over in Abu Dhabi. Mark didn't have to go out and find great transplant physicians and start a program from scratch. It was the Cleveland Clinic program that helped partner with the folks in Abu Dhabi to create that, because what is in Abu Dhabi is a Cleveland Clinic transplant program. And it's the same thing as you go down to Florida as well, and we started those programs down there. So we use that methodology to leverage that across the organization. You still run into many of the challenges, which are the historical issue of site specific. There's always somebody who's thinking about just their location. So there's still this cultural aspect that we still deal with. And this relates very importantly to value-based care, because value-based care shouldn't be about where the location is that we provide that care to the patient. It's really is what is the best for the patient. What is the best service? And a lot of times the best for the patient is not having that surgical case done. So making sure that those types of alignments exist across the organization. I think it also fits into the previous conversation of, rolling financial forecasts, because in this, we've had to change the way we measure performance in the organization. And we still have many of those traditional site-specific P&Ls, but it required us to put in place, how do you actually measure performance across the entire enterprise for heart and vascular, for neuro? And if you really think about this, it becomes very complicated because you can't measure it one way in our organization. You really need to think about it from a matrix perspective and leveraging that across the organization. And this also facilitates as we pivot towards that value-based care, and you think about capitated models, or in the case of, getting incentive payments that might be 18 months later, right? If you've got a model where somebody's just used to the fee-for-service type of transaction, how do you align that check that comes in 18 months from now for value-based to that individual's activity today? And this is where sitting down, and for us, one of the things that helps us is we have a straight employed model. So none of our doctors worry about, well, how is this going to impact my paycheck today? That gives us the flexibility to do that. But also taking those dollars and spreading them across the enterprise, not just based on those individual services, is incredibly helpful. And I think one last comment I'll make as well is it requires you to really shift as an enterprise to thinking about managing the entire enterprise every single day. So, when you're out in a hospital, if you're the CEO of the hospital or the CFO, you wake up in the morning, you know what the activity is in that hospital. But as a health system, we really need to do that every single day as well, which, at the clinic, we have daily huddles. So I stepped out of the tier 6 daily huddle to come do this panel today. And that's where across the entire enterprise, all of the activity that rolls up for that day is discussed today. So we know exactly how many cases we're doing today. We know exactly what kind of patient safety issues exist today. And as you talk about this evolution of financial planning, we now know what is our revenue every single day. We know every week I'm giving my CEO, here's how much I think the performance is going to be for this month. Even if it's the middle of the month, I'm telling them, I think we're going to hit budget. We're going to be $5 million off. This is what that P&L looks like. It's driven by revenue issues. So really trying to have that really robust financial performance model that supports that.
Well, thank you for letting us steal you away from your huddle today, Steve, to tell your team we appreciate it. When I was interested is you talked about a few things that have been helpful tools as you've made the transition and are really trying to drive that mindset that the employed model, for example. Are there any other, any other advice you'd give to people in terms of some of those tactics that have been really helpful in building buy-in, around this type of structure?
Well, I think it goes back to actually what Burt was talking about when he joined Intermountain. I was recruited to the clinic at a very challenging financial time at the clinic. And when I came on board, the clinic was losing money. So when you talk about turning that around in a large enterprise, having the CFO be the only person who understands how we're performing or just simply reporting that out. In my 18 years there, we've had an incredible track record of consistent financial performance, but that's built off of the fact that we worked very hard back then to educate everybody across the organization as how this works. Because think about it, we can't be successful in our industry of managing cost in a value-based environment if the frontline caregivers don't understand what that means. And that's no different than going to any other industry and saying that, the field people don't understand the cost of their product that they're trying to sell or manage.
Yeah, absolutely. Well, and that's where having cost information that people can rely on and trust and have access to is so critical to that journey. Thank you, Steve. Karen, I wanted to kind of pose the same question to you. I know you had talked a little bit about some research that your organization had done around really looking at value and how it ties to, cost structure and incentives. Would love to hear your insight as well.
Sure, absolutely. So cost is a huge focus of our organization daily, constantly. In Southern California, as I mentioned, it's a highly penetrated managed care market. So margins are always very slim and costs are a go-to opportunity, like I said, on a daily basis. You mentioned some of the research that a few of my colleagues were involved in. This was in conjunction with IHI. Helen McPhee, who's our Chief Transformation Officer, and Dr. Jim Leo, who's our Chief Medical Officer, published a white paper. It titled Driving the Waste Out of the System and Returning the Savings to Patients and the Economy, effectively also called the $1 Trillion Checkbook. And as part of their research, worked on identifying $1 trillion worth of waste in the health system. And what was interesting is a lot of it, if you looked at the big dollars, identified, $100 billion related to diagnostic error. A lot focused in the clinical areas, duplicate testing, unnecessary testing, those types of things. And so as part of that, they've really been championing, along with our physician society, looking at those things. How can we serve our patients better by making sure that we don't do things we don't need to do, making sure we're addressing all the opportunities to ensure we reduce diagnostic errors. But it was interesting to see the focus in those areas. And so a lot of work in our organization going on, focusing on that. In addition, as I mentioned in my introduction, we've been focusing on lower cost sites of care. That's why we've invested in a lot of freestanding, imaging, sort of non-hospital based services. A couple of other areas we've been focusing is robotic process automation. So that's something where we've just begun our journey there, initially focusing in the administrative areas. So, revenue cycle, supply chain, human resources, those admin areas, but beginning to look in clinical areas as well, pharmacy being the first one, but identified just in those handful of areas about $12 million in savings per year just there. And so we see that as an ongoing sort of we're never done type of IT implementation that will constantly be looking for areas where we can deploy additional robots to gain efficiency. One more area that's been a real help to us has been what are called hospital efficiency improvement programs, or HEPs, as part of our clinically integrated network. They're focused initially on quality, but also identifying areas for cost savings. So an example would be in orthopedics, where we create a HEP with our orthopedic surgeons. Those that participate come together to address quality and sort of consistency and practice opportunities, but in addition, cost savings opportunities. So for example, deciding to limit the number of vendors that we work with for implants, moving from 5 to 2. And in that example, doing so, whatever those savings are, we're able to legally share back 50% of the savings with the physicians. So they've been really motivated, and that's been a great success for us. In our initial year with a number of HEPs, we saved about $9 million. So those are a few of the savings initiatives that we're exploring, and we'll be looking for new ones constantly.
Yeah, I think that being able to prove the theory that improving quality can also improve cost structure. I think sometimes people assume that those things are always combating each other, but it's really not the case. I'm interested in just your experience too in bringing clinical leadership to the table with finance in those efforts, and if there's any lessons learned that you all have had through that process.
It's been the way we do business here at Memorial Care for a while. As I mentioned, we have what's called a physician society. And so this is a group of physicians that have pledged to best practice medicine. And so they're an entity that reports directly up to our board of directors. It's only physicians. So they have a seat at the table, much like a hospital board or CEO would. And so we've had that relationship for quite some time. They're very much a part of what we do, strategic planning and so forth. And so, for us, it's pretty natural to work closely with them. And it's led us to some very nice results clinically and financially.
That's fantastic. All right. So one more question for the group here. Really a two-part question. One, as we've kind of gone through this journey with the pandemic this year, I feel like many of us have found ourselves kind of moving past this response mode and really looking for opportunities to reinvent and think about how we can drive this to drive long-term positive change. So I'm curious about what you all are optimistic about as you look forward. And the second part of that question is just if you have a quote, a saying that provides inspiration to you that you've drawn from over these past few months. So wanted to point this one to Melinda and Steve. Maybe Melinda, you can go first.
Sure. So, I think there are a lot of things. When I first think through what's happened in the last 6 months, there's a tremendous amount of innovation, tremendous amount of creativity. And the power of what we can do when we come together with singularity of purpose. When you think about the speed and the magnitude of the decision making that we've had to do, it's kind of like bringing all the different skill sets that we've all learned over our careers all together at once, and a tremendous amount of trust. So, our leadership team, as we came together to think through constant decisions on an ongoing basis, is a tremendous amount of trust, but also a tremendous amount of innovation. Our very new Healthcare Innovation Consortium got a huge workout as we came up with new thoughts and ideas and threw ideas at them and said, hey, help us solve this, and they did. And so there's a lot to be proud of that I don't want to lose sight of. As we kind of started bringing back our old projects and bringing back, say, well, what about this? We need to revisit this. It's also forced us to rethink meetings, rethink bricks and mortar. Who actually does need to come back on site? Who actually, how do we want to work going forward? What does it look like? What does the workspace look like? What does the work day look like? Is it really 8 to 5? Is there a flexibility? What does that look like to help accommodate childcare, to help accommodate school-age children who mostly are at home right now? It really has allowed us to think very differently about staffing models and about now space planning. So that then falls into the bricks and mortar and how much do we really need? So there's a lot of things that are going to come through this that I think we're going to look back on this year as really sparking a lot of good conversations. Yeah. So I do keep a Bible verse on my desk that that is whatever is true, whatever is honorable, whatever is just, whatever is pure, whatever is lovely, whatever is gracious, is there any excellence, if there's anything worthy of praise, think on these things. To just always remember to find the positives in the world. And so really just, I think there's a lot of good things that we need to make a focus. In 2020, I think we have a list of the bad. I think there's bingo cards being circulated about the bads, but there are a lot of goods.
Yeah, I think we can relate to that here at our company too. It's forced us to think differently about how we work together, and becoming a team that can work effectively even if we're not in the same room anymore. So there's definitely some positives coming out of that.
Yeah. And one more thing I meant to add too is also patience. As a safety net, one thing I meant to add is making sure that we see our patients where they are. We're so good at saying, come here. And instead of saying, no, we need to meet patients where they are. And that means, I think Steve mentioned earlier, or I think it was maybe Karen, the wraparound services. Just because we have you on telehealth now and we had the same explosion of telehealth, well, now what about the labs? What about the imaging? What about, we haven't figured that out, telehealth yet. So we did launch mobile phlebotomy. How do we think about the wraparound services? How do we, Wi-Fi is not available to everybody. So how do we, there's some real fundamentals here.
Absolutely, absolutely. And Steve, how about you?
Yeah, I think leveraging what we've all been forced to do on the technology platform, I think is the biggest opportunity. If I look back at our history here, we've been doing e-radiology for 20 years, EICU across the enterprise for a decade. We have the biggest, largest epilepsy program in the world. But these are examples, it's not built in across the entire platform. So I think this has really forced all healthcare providers to embrace technology, much like we're doing right now, to do this panel at a conference. So how do we continue to do that across the entire healthcare delivery model? And, we had so many of our caregivers that were forced into it in April, right? The big spike we all saw in telehealth. But we would all acknowledge today that we've seen that kind of drop down a little bit, or at least we have. We were up around almost 60% of all volume was a televisit. It's not quite there. Part of that's the recovery, but we're so much further ahead of where we are. How do we embrace this really in order to drive that in every single facet of what we do? Just the whole idea that, we don't allow travel across the enterprise right now and not for the remainder of this year. So part of that is the COVID environment, part of that is cost management, but part of that is really forcing people to say, well, as you work with Abu Dhabi, as you work with Florida, as you do this, you have to figure out how to do it through technology, through those platforms. And I think that's going to be the biggest thing that really creates opportunity for us. I get excited about how many times we can then create those centers of excellence across the entire organization. It improves the quality of care that gets delivered to the patient, and it can reduce the cost. It's a win-win, in the healthcare environment. And, as far as a favorite quote, if on the wall in the gym of my house, I've had a quote up there for well over a decade, and it says, "Today I will do what others won't, so tomorrow I can do what others can't." And I think it's important in healthcare because there's a lot of hard work at what you have to do today in order to innovate tomorrow. And I just, I use that in my personal life, but also in my work life as well.
Yeah, it's interesting too with just access. You both kind of hit on this. I mean, obviously different than providing healthcare, but the fact that we were able to bring all four of you together today, that may not have been possible if everyone had to travel, to Chicago for our conference. And, we saw in the number of people that are able to join us today, it tripled, nearly quadrupled based on this being virtual. And so there's more people that can hear that story and be inspired. And so there's a lot for us to learn from and grow from this experience. Well, I wanted to just thank all of you for joining us. We really appreciate you taking the time to share your stories, share your insights with our collective Strata community here today, and really for all of the folks in the audience as well. As John mentioned, healthcare providers have been the true heroes here, and we're so grateful to be able to serve you here at Strata. I am just going to close with 3 things, but we'll let our panelists drop off as we come to a close. So thank you again, everybody.
Thank you all. We really appreciate it.
Thank you.
Thank you.
So 3 things to leave all of you with as we close the session here. So first, normally around this time today, so going into the second day of Summit, when we're in person, I would find myself talking with people in the hallways or over lunch about what things really resonated with them from what they've heard and where they plan to take action. And since we're not able to do that in person, what we're offering is really to hold a executive briefing around the summit for all of our customers. So these are 60-minute sessions where we can really talk about what you took away from the summit, explore some of the things you heard about, whether that be market trends or innovation we're doing at Strata or how other organizations are leveraging our solutions, and translate that into what your plan of action or roadmap looks like. So all of you will be receiving an email after the session today where you can sign up for a slot with our team. Next, in case you missed it at the keynote yesterday, wanted to announce our 2020 LEAP Award winner. So for context, every year Strata selects an organization that's really gone above and beyond to lead, excel, advance, and make progress. And in other words, really allow their organization to take a leap forward. So this year, as we thought about candidates, there were an extraordinary number of organizations that have stepped up and delivered heroic efforts this year. And so I'm excited to announce or re-announce that our 2020 LEAP Award winner this year is you. All of our clients, we feel, really deserve the honor of that award. So we'll be sending an award out to the executive sponsor at each of your organizations. So make sure to check in with her or him once that arrives. And we really hope that this provides a smile, a sense of pride, in the work that you all have done and really stepping in when healthcare needed you most. And finally, as John and I wrap up, we were thinking about how honored we are to really serve you all as clients of Strata. And the journey that we've gone on this year has really been one that we've gone through as a team. And that team applies here at work, but also at home. So all of you had a chance to see mine and John's family photos here at the beginning. And we thought we'd leave you with a little bit of inspiration, not just from our families, but the collective of some of the folks at the home team here at Strata and their perspective on why the work we do is so important. So again, thank you everybody and enjoy the rest of the sessions today.
It's important because then if there's no healthcare, people would all be suffering.
My daddy helps us to take care of sick people.
Strata helps their customers provide better care for their patients.
Our first responders with our technology.
They help hospitals.
My dad helps test the software to make sure that they work.
Helps doctors and nurses with their money so the hospital can work.
Help heal healthcare means helping hospitals stay strong so they can treat us in times like this.
And you help our heroes with Hero Sidekick.